Hi, everyone. Good afternoon. Good morning. Good afternoon. Glad to see you all here for our monthly community conversation. I'm here with Hannah and Neftali. And if you've joined our first community conversation on this topic a few months ago, you will, this will be a little bit familiar to you, but just glad you're all here. Hope everybody's having a good day. We wanted to bring people together this month to give a little bit of space to check in a few months after the new administration has come in. There's been a lot going on. And I think a lot of different areas to put our attention, right? Each day it seems to change. I wanted to just kind of kick us off and share with you a little bit of my personal experience with some of the changes, and a little bit about how I've been feeling about it, but not too much on that, to give us space to kind of talk through challenges and opportunities here. So a couple of things have happened in my work related to the administration. So I do some work on overdose prevention and education for providers on that. So behavioral health providers and medical providers in an MCO in Arizona. And then they sort of take that overdose prevention work and weave it into obviously their integrated care systems. And we had done a ton of training for them, and it happened to be, I guess, under a COVID-19 named grant. And so we got a stop work order for that grant maybe about 2 months ago. So we effectively stopped our trainings on that, and that was sort of a gut punch in terms of like how this actually impacts my work or other, individuals who are training and obviously patients and stuff like that. As of this weekend, the stop work order was rescinded because of some judicial work, which it was challenged in the courts. And then now we were told to begin work again. So it's I think, that story has been happening, right? I have a cousin who was sort of laid off because of this and then asked to come back to work. So a little bit of a whiplash, like ups and downs, good news, bad news, right? So in that case, it is good news. We'll be restarting that sort of overdose prevention work and excited about that. So I just sort of wanted to share a little bit about that before we get too far, just to like, and I'm happy to share more. But we're really here today. Neftali's going to lead us in conversation around challenges and opportunities that we're seeing at this point, and really give you all a chance to kind of participate in any way you want today. So once again, just glad you're here. And Neftali, I'll kick it over to you.
Yeah, thanks, Stacy, and hello, everybody. Thank you for joining us today. On camera, off camera, we're glad you're here. And so I think I'll just make a couple of sort of remarks similar to Stacy around my personal experience. So actually, we were talking right before this meeting that we've definitely noticed in our own spheres and here as we work in CFHA, an energy shift. I think we've noticed just people being fatigued and feeling worn down by the last 4 months of our collective lives, and I think that's just something to notice. It's okay. I think that's what we would tell our patients, right? Like, are you tired because of a hard situation? That's okay. The fatigue is not a problem. It is just a sign that you need to take care of yourself and they need to rest, right? And I can personally tell you that that's certainly true of myself. I've had more personal moments of depletion in the last 4 months than I usually have in a typical 4 month period. And that has caused me to recalibrate some. And so, from a member standpoint, we definitely experience that sometimes in terms of like just a little bit less engagement, just less folks just having less to volunteer in terms of time and the like. And that's okay. Like all of that is okay. And I just want to make sure that we all just affirm ourselves that we need to take that space. We ought to take it. Um, so that's, I think, helpful just to take note of where we are in this point in time. The other side of that, however, is that there are actually a lot of positive things that we can take, even when the situation doesn't feel positive. And I think these two comments relate to each other because we've experienced fatigue from a lot of hardness, for lack of a better word, a lot of messed up stuff that we've experienced in the last few months. But the fatigue doesn't mean that actually there hasn't been a lot of positive work that's actually happened. And I would say, on the whole, uh, probably those folks who've been advocating for healthcare related elements um, and providing pushback have probably been more successful than not to this point in providing pushback when you just look at it objectively. So, again, you want to separate how it feels from like some of that objective reality. So a lot of that is through the slow legal process that has provided that pushback. So Stacy's story is actually a more typical story than not, right? A story where there was pushback, the courts provide a hold and restoring funding. That's probably a more typical story when it comes to healthcare related stuff than other things. Of course, that does nothing for you if your particular research has been cut or your positions have been cut, obviously. But on the whole, that's the general narrative. It just doesn't feel that way because, well, for obvious reasons. I don't need to tell you why it feels so bad. So I think that's something for us to also note that the feeling of fatigue is different than the sort of objective realities of what has been able to be achieved thus far. And that all got me thinking and got me wondering what you all are thinking as well, because I think one of the things that has become clear is that there are changes that are being made and changes that will be made, and there's disruption as part of that. And disruption uh, provides also opportunity. So far, our efforts, and we will continue to do this as a larger community, have been directed at resistance, right?
Mhm.
Stopping the things from uh, keeping important work from going forward. But I think it's also important for us to be strategically thinking about what we actually want to be the case going forward, because we have an opportunity to shape the future, if not during this administration, then hopefully immediately after the administration, right? And so our message really shouldn't be just, hey, stop what you're doing, this is not right, and put it all back together exactly the way it was, because especially our community, we were saying, hey, this is not all right, right? The way this works doesn't work well for our patients in our communities in all circumstances. So creating a vision and beginning to create a vision for what we actually want to have happen, I think is important to do for that strategic reason. I think it's also an important shift psychologically because it puts us into a place where we're thinking proactively about change and hopefully entering a more hopeful, empowered space. So I'm going to briefly pull up a one slide just so we have a visual of the categories I want you to think about. And what I'm going to ask you to do is I'm going to ask you to um, essentially think through these categories um, and think, what would I, if I had the opportunity to, um, you know, uh, eh, you know, influence the way that this particular organization works, right? What would I particularly be able to? What would I want to have happen? What would it look like if I were able to do this? So give me a second here while I pull up, if I can find it. Sorry, I thought I had this pulled up, but I do not. And now I've lost um, I've completely lost this thing. That's very appropriate for this. So I'll just visualize it for you. So here are the buckets, right? So bucket number one is, what is the structure of the federal government? Because that's one of the things that, and I don't mean the entire federal government, I mean related to health and human services, for example, CMS. So an example would be, we know that like SAMHSA, as it's currently constituted, has been restructured, right? And somehow sort of reabsorbed somewhere. What would we want that to look like? Were we okay with like HRSA and SAMHSA being two separate agencies? Was that the optimal way to think about it, right? I'll give you my opinion. I don't actually think that was the best way to structure that, because as a integrated care champion, I found it very hard to interface with those two different agencies. One's focusing on substance abuse and mental health stuff, and the other one focused on primary care and other stuff, medical related, right? So maybe that wasn't the best way to deal with that, right? So that's structural questions. Another category is workforce. So workforce, things like GME program. Notice the GME program, graduate medical education, separate from the GPE program, graduate psychology program. And there's no real program for like LCSWs or LPCs, right? Funding that. Do we want those two programs to be separate? Do we want to revision the way the federal government supports residency education and graduate mental health education? Is there an opportunity there to maybe change that into maybe an integrated program potentially, and something that does support non-psychologists as well as psychologists as part of that bucket? So workforce is another. Research and academic institutions, some of you might be in that bucket, and you know how challenging it is to work with the federal government on your research grants. And you know the elements of that that might dissuade really good researchers from actually doing good work in that area. Is there a different way that we wanted to approach research and research funding um, in that space, right? And then uh, funding for just clinical service delivery, right? Are there things that we would want to see different out of HRSA, out of CMS? Um, so all of these are different categories that I think we can begin to create a proactive vision around and say, hey, if we're going to put this back together, let's at least put it back together in a way that makes sense, especially from our standpoint, from the standpoint of caring for patients and families in a more coherent, integrated way. So that's my pitch to you all today and my question. So we're a small enough group where you can definitely chime up if you like. Stacy has some facilitation questions she might throw in there as we go. But as you sit with this idea of thinking through what would you like to have happen, my first question is, what is it that immediately comes to your mind? And with the caveat that this is all brainstorming, right? This serves as sort of fodder for us here at CFHA to kind of hear from you, early thoughts, but don't feel like it's got to be perfect. My idea of putting SAMHSA and HRSA together might be the worst idea ever. I haven't researched this idea up to the wazoo. This is just a brainstorm. So please feel free to be brainstormy about that and say, hey, yeah, if I were to take advantage of this opportunity, this is one piece that I would like to see different out of my federal government.
Thank you. Thank you, Neftali, for kicking us off. Want to leave some space. Does anyone have any reactions to that, or did you bring anything you wanted to share today on how it's going on your end? You can also use the chat if you don't feel like coming off mute. That's fine too. Okay. Well, people can just jump in anytime or raise your hand or however you want to do it. So in addition to sort of thinking about what might we want, right? I think, I've been thinking a lot about, in a way, this is actually starting to follow kind of a predictable playbook. And I take a little bit of comfort in that. If anyone on the call has ever worked in a startup or not necessarily corporate, but I'm talking about a VC-backed startup, this actually feels pretty normal for that kind of, but it's happening on a scale, I think, for people that aren't used to that kind of work. And what I think can be important right now is this administration has been really good at resonating with people because it sort of cuts nuance and explains things to people in sort of these really quick kind of soundbite things that you can get behind, right? This isn't working because of this. And people are like, oh yeah, okay, that makes sense to me, right? And so you get a lot of following around that. And in some ways, the rise of social media, mental health, TikTok is doing kind of the same thing, right? There's some research coming out showing that most of the mental health TikTok just cuts the nuance. 50% of it is misinformation, but people want to learn. I think the key takeaway here is that people want to understand medicine. They want to understand behavioral health. They want to know what's going on with healthcare. And if you can explain it to them in a simple way, that's helpful. And, to be honest, I don't think those of us on this call and in this industry are very good at that, right? Clinical people are not very good at cutting the nuance and just giving an answer or a position. That's not how we're trained, right? And so actually would see that in a healthcare startup over and over, that the clinical people would be overrun over and over and over because we would explain things for 100 years. Everyone's eyes would glaze over who are not clinicians, and the clinical voice started to drop away and that expertise. So I think if we can sort of, take our break, regather our energy and come back and get a little bit better at sort of honing our message is kind of what we're trying to do today. What is it that we're behind? What's working, what's not, and get there a little bit faster that people can understand. I think that actually is working. I think advocacy is working. I think we're seeing people on both sides of the aisle push back on some of the things that are being proposed. Not all Republicans seem to be behind everything and are really advocating for some low-income folks in their states. So I find that encouraging, despite, everything that's going on. So would love to hear people's thoughts on any opportunities or things like that you're seeing. Or, you can take an opposite view too, things that are not going so well. That's fine.
Hi, Stacy. My name's Tiffany. I'm a nurse in Colorado. I've done a lot of work with CFHA and have done a lot of integration with our nurse-led practitioner clinics here, and has been great and has been real successful. It's been a 4-year labor of love. What we're finding that's been really hard is we are having to change a lot of our language around education in order just to get grant funded. And I don't want to make this a complaint session, but I'd like to, and I really, when you're talking, it just keeps hitting my heart of really just wanting to reach out to the community of beautiful community of CFHA, with my tail tucked, but, because I'm trying to write these powerful grant initiatives that show how much, diversity, equity, inclusion. And that doesn't mean, it means everything, right? It doesn't mean just LGBTQIA plus 2S. It doesn't mean race. It means everything, right? So we cannot use so much terminology, and I don't know how to write these powerful initiatives that integrate behavioral health into these clinics, which we know are life-changing and transforming, without using terminology that talks about the diversity of human beings and why behavioral health integration is the key in helping these people actually get better.
Mhm.
And so I'm struggling. I'm really struggling with that. I feel like I'm just beating around the bush. So I don't know, just your thoughts on that,
Yes.
or if anybody has experienced this, because
Yeah.
I'm using AI to say, hey, I can't use these words, and I don't want to use AI because I feel like that's not coming from like my heart and my soul. So I'm like, I'm just
No.
really struggling as a project director here at the center. And I mean, I'm one of the lead project directors on our behavioral health initiatives, and I'm stuck.
Yeah,
So
I'm glad you're bringing this up. My opinion is use AI. I mean, that's why not, right? We can talk all day about that. I think we should do a community conversation on that too. I had a similar incident where I was doing an IPV resource for providers, talking about, and the word birth control was on the resource, and our project manager kicked it back and said, didn't tell us to change it. So I don't want to say that, but was worried about us using the terms birth control. And I got so mad because it was a IPV resource, right? Of all things. So I hear you. And I think part of what's going on is one, that we know these things work, they're really important, and we've sort of built our identities around sort of the good fight and having these things kind of like out there in healthcare. But I hear you. So, I mean, if anybody's got any stories like this or ways that they're kind of changing language, I'd love to hear that. I don't know how else you say birth control, but please, if you've got an idea, please tell me.
Yeah, happy to have other people jump in. But as you're putting your thoughts together, I think a key differentiator that I use is um, I think you have to decide when language change is necessary to sort of defend your funding versus when it's just purely out of fear.
Hmm.
Because in most of these instances, you probably have an opportunity to get your hand slapped and then correct if you need to, or at least in some instances. And so I would encourage people to, when it's appropriate, like just say like, hey, we're not going to necessarily lose funding over this. We're just worried that we're going to hand slap. Well, maybe that's a time when we don't like work extra hard to change language, right? It's sort of compliance right up to the line. And the truth is, we've been doing that in healthcare for a long time
Mm.
for a lot of issues, right? A lot of compliance issues. We might wait till we get our hands slapped, then make a change. Now, there's other situations where it's like, no, we need to, like if you're applying for a grant, for example, that becomes an issue where you're like, yeah, change your language and try your best to, you know, use AI to be creative around it, or seek specific counsel. Like if you have a project manager or like a program manager for that fund, ask them, how would you like me to say birth control,
Hmm.
right?
Hmm.
Just so you get some very specific feedback on that and raise the issue as well, right? Because some of these issues you cannot beat around the bush on. Like
Right.
there's no way to reframe birth control and mean the same thing, right? Whereas there are different ways to talk about DEI without using those words, right? So I think being smart about language is important. I think the other thing I would just note is I think this is actually, and this is the sort of ACT-based therapist that is coming out here. I think there's actually something healthy about having a healthy distance and attachment to language and words,
Hmm.
um, because language changes naturally over time. So DEI is language that, in fact, is fairly new to those of us who've been professionals for more than 15, 20 years. There's always been something related to like diversity, for example. but the words diversity, equity, and inclusion are pretty fairly new in the healthcare space and in the larger space, and they were bound to evolve and develop. So then again, I would say then use this as an opportunity to evolve and develop and say, okay, let's use this not as a regressive opportunity, but actually a opportunity for growth. And what's cool about that is that I have seen communities do that. Whereas, like, I think it's been poorly understood that DEI was more than just racial or sexual preference categories or gender categories. Now people are really saying, well, no, DEI is also about our veterans. And it's about, you know, folks who are not able-bodied, right? It's actually helped us evolve that language to really remember, actually, this is the goal of DEI. DEI is actually providing a space for all people, right? So I think that's a good thing. That's a positive thing. All right, great. We're not talking about veterans, and we're talking about people, students with disabilities, and et cetera. I'm curious from you folks out there as well. If you were to like, you were in charge of CFHA, and you know, you wanted to uh, have your say related to how we put things back together in whatever category, what would be the main thing that would affect your day-to-day life, or you think improve things for you as a person who's passionate? I'm assuming everybody on this call is passionate about team-based care. I'm assuming everybody's passionate about um, interprofessional care and interprofessional education. Um, you know, passionate about workforce development efforts, passionate about care for underserved groups, et cetera. What would you want to put together sort of differently, or perhaps I guess you could say what is really important for you to potentially defend as well? I'm just curious where your mind goes when you think of yourself in that space and think, oh, what would I change? What would I, or what would I promote? How would you like us, in other words, as an organization to represent you?
Yeah, I think we can.
Any thoughts? Or I can just also, uh, sometimes people like to be asked to participate. So I can also do that if you're wanting to be asked. And I'm trying to resist asking you, Arissa, just because you have your camera on. I don't want to penalize you for having your camera on, but you know, certainly feel free to unmute if you wish. I know we've got I don't know if are you able to come off mute, Jen? Jen Thomas is our medical director. If you
Yes.
are able to,
Yep. I'm
okay.
sorry.
I don't know if you're in clinic.
Yes, I'm in clinic, so I'm like trying to like multitask and be off camera when I can. But no, this is great conversation. I don't know. I mean, it's hard. I'm a medical PCP. I do addiction medicine work. I don't know, fee for service. I still feel like we're under the thumb of you eat what you kill, and you're only as good as how many patients you see. And if there's any way to, I don't know if that's value-based care conversations, but that's where I always end up going just on the clinical side. Is it just feels so like, will we ever get there, or will it be in my lifetime to feel like we're valued for actual like quality and not just widget making and, you know, turn and burn. So kind of pessimistic. Sorry, guys.
No, not at all, but that's helpful. That's kind of some of the feedback I'm looking for. And there is opportunities in those spaces, because there is actually some energy there, I think, for value-based care. Um, and one of the impetuses for that, I think, is actually the administration's emphasis on chronic disease management. Because if you think about it, chronic disease management is best cared for in a value-based arrangement, right? Because if you just incentivize visits for, say, managing diabetes or COPD, or, name the condition, that's a very poor use of resources and money. You'd want to incentivize team-based care so that the person could access a nutritionist, could access a health consultant, access clinical pharmacy, access their PCP. But then you also want to incentivize innovation in terms of like remote monitoring. You want to incentivize care management, et cetera. And all of that is best cared for in episodes of care and sort of bundles of care that encourage organizations not to just fill their schedules and then, churn out a bunch of E&M codes. So I actually think, Jen, that that's a conversation that is more likely to happen in the near term. I mean, it's already been happening, but more likely to gain some traction pretty quickly. And I did see something, I didn't read it all the way through, but CMS did put something out around value-based payment methodology and how they're dealing with it going forward, and a continued interest in moving more payments to value-based payments for Medicare. It was originally the case that by 2030, all CMS, I think it's 2030 or 2035, all CMS patients were supposed to be value-based or majority value-based. That was the original plan. That's no longer the plan. But I think they're still kind of putting together what the replacement plan is going to be to that end. But that's a good example. So value-based payments is one of the things that I think would help team-based care in general. Any other things that come to your mind? Like, how would you want CFHA to represent the things that are important to you as we think about putting this all together?
In the chat, we're seeing orgs obviously talking about the financial repercussions and probably worries and realities of funding cuts.
And the biggest piece there, of course, is the budget. And that's ongoing right now. So for those of you who have been checked out, I'll give you the update on that. So the budget is being put together in the House, as it typically is. And it's out of committee. It passed out of committee. But there is some question as to whether it will actually pass the House as a whole, because there's a very narrow Republican majority, and because there's lots of elements of the bill, particularly the healthcare related parts, that are very unpopular, including with Republican constituents.
Right.
So there's in the Office of Management and Budget, OMB, came out yesterday with basically a prognostication about the budget, and affirmed that I forget the exact amount, but it was a lot, would need to be cut under the current bill structure from Medicaid, and not only Medicaid, but also Medicare, which previously has been, talked about as not untouchable. So my suspicion is that whatever it is now, this bill will have a difficult time passing in the House. If it does pass in the House, it has an even harder time passing in the Senate. The Senate is preferring a piecemeal way of approaching the budget, so passing specific items piece by piece through the reconciliation process. That is not the big, beautiful bill that the House wants to pass in one fell swoop. And so all that is still at play. The moral of the story there is that the collective we in healthcare are doing a very good job, I think, of actually telling the story of the importance of Medicaid. Less so Medicare, because it's not really been talked about as being specifically under threat, but Medicaid in particular. The role of FQHCs has been we've had CFHA members going up to Capitol Hill, advocating individually. So some good work has happened, and actually that is producing the results that you see right now, which is this is not passing very quickly and may not pass in any sort of fashion similar to what we see right now. But that's the current update. So Tiffany, does CFHA ever go and advocate in person for change? So we're, it's probably more accurate to say CFHA members certainly do. CFHA itself doesn't have a lobbying arm or you know, specific way in which we might do this, other than we belong to, on your behalf, a group called the Mental Health Liaison Group. And that is a group of organizations all over the country that together keep track of and advocate for mental health related policy in the country. So if you remember way back when the suicide hotline was being promoted as a bill, right? So that's something we signed on to on our members' behalf. So we have been signing on to many sort of bills, letters, statements in these last few months that that organization, on behalf of all the organizations that are under it, have put out. So that's the main way that we advocate on the federal level. And then individually, we just know that there's like last week, one of my good friends in Madison, Wisconsin, was in DC on behalf of their federally qualified health center and all federally qualified health centers in Wisconsin, advocating with their representatives in Congress in DC. So that's something that individual CFHA members do. And it really does make a difference. Like the calls make a difference, the letters make a difference, going makes a difference.
I think that's a good point, Tiffany, that you make, and a great request that kind of maybe goes to communication. Maybe that's behind that request. Like when you're saying support when speaking to lawmakers, it's like, what do I actually say when I have such a short amount of time and they don't really know much about the topic? I can relate to that, and I think that would be really helpful if we could sort of like boil things down succinctly.
Right. And Jen points out something else that I forgot is that we also, when states come to us, we help them basically organize themselves. So like Jen's talking about a group in Illinois that's organizing around COCM advocacy. So we provide the platform, bring people together, and help promote that so people can come together. So if you wanted to start something like that, all you'd have to do is reach out to myself and Hannah, honestly, because we're the ones that usually run that kind of thing. And then we can figure out the best pathway for getting that going in a state. So we have a group in California, we have a group in Georgia, we have a group in Illinois, we have a group in Tennessee that hasn't been meeting as much, but a year or so ago they were meeting. And then we also like participate on groups that are already established that ask us to participate. So there's a group in New York State that is already established, and we just sort of periodically meet with them. Yeah, and Colorado would be a really good state for advocacy for sure.
And Tiffany, this is Jen. Sorry, I'm not on camera, but that group has been really helpful with the advocacy policy piece. I don't know jack about that. I'm a frontline clinician, but what I can tell you is when we've got this group together with people from my state, we got stakeholders from Illinois Psychiatric Society, which is a branch of the APA. We got folks together from our chapter of AAFP that's statewide. So there are stakeholders there that I would never have met or worked with, and then hence their lobbyists that can actually help you do some of that connection. Because I don't know about you, but when you're in clinic with the patient in front of you, the lawmaker and the decision makers feel a million miles away, and it's really frustrating. And it really makes you feel kind of like, what the heck can we do as the frontline people talking and caring for patients? But I don't know. Personally, I've just found that our statewide group has felt like at least we have some actionable connections in meeting people that have those relationships, because it's all about relationships end of the day, right?
Mm-hmm.
Yeah, collective action is a real thing. Like when you just get a group of people together, like it makes a difference, right? Especially when those groups represent other groups. So no matter how small you are, and CFHA is a very small entity, but we kind of punch above our weight because of who we represent and our friends. We've got lots of friends in the world because we're a friendly group of people, and we invite everybody, right? So that really helps, and it makes a difference. And so people then listen to you. And I think there was another part of that too, Stacey, that you mentioned around like how to kind of do the advocacy. And
Yes.
I can just give you guys a quick primer on it because it's super simple and straightforward, right? So whether you're doing this in writing or in person, there's really two things that you want to do when you're doing advocacy. Number one is state the problem clearly,
Mm-hmm.
right? Because you don't want to assume that the representative, or a lot of times you're not talking to the representative, you're talking to like a staffer on their team, that they know what the problem is, right? Because they've got like a bazillion people throwing problems at them, right? And they may not have a clear sense of it. So, but you want to state the problem in as clearly as possible, right? And that also keeps you from just complaining, right? You don't want to just complain to representatives and to people in power. You want to state a specific problem that you want
Can you give an
solved.
example? Not to put you on the spot?
Sure. Yeah. So, like, let's say Medicaid cuts, right? So, instead of saying, I don't think Medicaid should be cut, it's really bad for poor people, right? That's just complaining. That's not stating a specific problem. You'd want to say something very specific. And this, if you've seen the email on Gaggle, this was part of what that email was about. So you want to say, hey, I'm a clinician and I know how hard it is for my patients to work through government bureaucracy. And if you add government bureaucracy to Medicaid eligibility, you're going to knock a lot of people who deserve Medicaid off of Medicaid, right? That's stating a specific problem, that this mechanism is going to result in that action, right? And I might obviously reframe that based on who the audience is slightly, right? Which representative, what party they represent. But step one is state your problem very clearly. And then step two is propose a solution. What is a better way? What is a way that might result in, better outcomes? Um, uh, and so, a solution is basically, hopefully, typically you have potentially a piece of legislation that you're promoting and say, this piece of legislation helps do X, right? And then they can refer to that very specific piece of legislation and language and then reference that as they move forward. But those are the two things: state your problem and then propose a specific solution. So for example, with that Medicaid issue, I think it's very important for folks advocating to not just advocate for maintaining funding, right? We know that's problematic if you cut funding, but what we really should be doing is also saying, what are other ways that we could align with the intention of increasing efficiency of Medicaid and efficient use of Medicaid dollars, right? Because that's the intention behind it, right? We want to make sure, as the House Speaker has said, that only those who need Medicaid get Medicaid. So we can say, okay, yeah, we're with that too. We don't think people who don't should be on Medicaid that don't need Medicaid, right? So how do we do that, right? That's where you would put in a specific policy solution. And there's lots of ideas out there around what might work in that regard, other than work requirements, which do not work, and just putting in a bunch of eligibility paperwork and all that kind of stuff.
That's super helpful. Thank you. It makes me think that hack could be useful in all kinds of conversations, advocating to your administration about any change, right? Or outside of it as well.
Tiffany, I'm wondering from your standpoint, sorry, not Tiffany, I meant to say, Stacy,
Mm.
I'm wondering from your standpoint, the PCAs have been very, very active. PCAs are the primary care associations across the United States. What are people focusing on primarily at the PCA level in terms of advocacy or trying to promote
You know,
federally
it's,
qualified health centers?
yeah, I think I'm in Illinois, there was, I'll just be very transparent. I think that the vibe that I've gotten is that even the folks at the PCAs have been have been a lot thrown off balance by what's happening. Not so much our advocacy folks, they've been really reassuring, that FQHCs and things like that have had always bipartisan support. We're still seeing funding come through for the NHSC stuff, right? They're still asking for applications for those. And I think there was some focus on that. But I think some of the vibe has been like, because things have just been the same for so long, right? And a lot of the folks at some of the PCAs that I work with have been in those roles for a really long time. So I don't think that they were expecting so much change as many folks on the call can relate. But we have seen like our funding continue. And some of that was very uncertain, but in the last couple months, the funding has continued. So, I have to check in a little bit with my policy folks to see what is new now, but that's sort of what I've been picking up on.
Yeah, that's helpful. And that's been my read as well, that's and it's sort of led to a rule that I have that might be helpful for you all to think about is the one standard deviation rule. So if I was a betting person, and I said, in 1 year, where will we be related to funding, related to structural change, et cetera? So we fast forward to May 2026. The likelihood is that we will be within one standard deviation from the mean. In other words, we're not likely going to be that drastically different from where we are today in 1 year. Why is that? I think it's fundamentally because I think what we've learned is that change is extremely hard to enable because there's so much interconnectivity, especially in the healthcare space. It's almost like you remove one piece and it has this domino effect going down. So an example would be the Medicaid cuts that are being proposed. So as you said, Stacey, that there's a lot of Republican senators and representatives who are hearing from their hospitals, especially their rural hospitals, but really all their hospitals. And their hospitals are saying, hey, if we see these Medicaid cuts, we may have to close, right? So that is an example of how this sort of overarching idea of creating cost efficiency in a program like Medicaid has an effect that these representatives and senators don't want. They don't want to see the rural hospitals closed. Those are important constituents they represent. That's a lot of their political base as well in those rural areas. So that I've seen time and time again with so many issues that, it feels like a Jenga thing. And every time they try to take something out of a little piece here or there, other parts of the system start feeling shaky. And that's where we've seen then, that a lot of that, we saw that with the NIH, where they fired a bunch of people and they're like, oh, we got to hire these people back because there's a lot of implications. We didn't think about that. They fired a bunch of people in the VA. Oh, we got to actually bring people back and not offer these early retirements to people, right? Because there's interconnectivity in our health system that doesn't allow you to easily take one piece and make transformation, cut costs without having this downstream effect. So that's my sort of standard deviation rule. Change is hard. We're very interconnected. More than likely, where we will end up budget wise, funding wise, structure wise, it's going to be one standard deviation from what we have right now. In some cases, hopefully, we're a little bit better. Who knows? Many cases, we might be somewhere lower than our mean right now, but it won't be as drastic a change as I think what has felt like in these first 4 months. You know, another good example is SAMHSA as an entity. I know that there's a lot of consternation. I share some of that consternation around SAMHSA being sort of liquidated as an entity. But the truth is, there's aspects of it that are just not going to go away because they're mandated by Congress, right? Like they have to be maintained in some way unless Congress issues a legislative change, right? They have to change laws in order not to support certain programs in SAMHSA. So will SAMHSA still be SAMHSA in a year? In terms of its function, probably. Will it be called SAMHSA? Maybe not, but the function will still be there. There'll be some functioning programs of sort. So again, that's where it behooves us to say, well, how would we like this new SAMHSA to function, right? What would be optimal so that it functions in a productive way, as opposed to just reacting to the fear that SAMHSA will go away. It's not likely to go away. It's just aspects of it that might shift, change, be reabsorbed into different offices. Once we define the problem that way, then we find our opportunity there.
Yeah, I agree with that. I think if anybody's got anything in the last few minutes, please feel free to jump in. I think, you know, take your breaks and take care of yourself, but I would recommend don't get out of the game completely, right? This is the time that we need clinicians, frontline people actually experts in healthcare to participate, even on a small level, right? And I think on a practical level, to go back to your question about PCAs, our PCA is doing a lot of kind of thought and funding experiments. Okay, like if we lost this grant, where would we be? If we lose this one, what happens, right? You have to think that way on a personal budget, right? Your own family budget. That's probably a useful thing to do. If our income changes in the next 2 to 3 months, personally, I've been doing that, right? Because I've gotten stop work orders and things. And then our PCAs are doing that. Our PCAs are also offering FQHC's compensation strategy workshops. So looking across your workforce as a whole and really being strategic about who's working and what are they doing and what's their function. And also in a positive way, right? If you've got 4 people with the title of manager and they're not managing anyone, why is it happening? Where's the career ladders for those folks, right? And this is a great time to be looking at all those things. Obviously, you've had to get through sort of your fear and that initial reaction, but this is the time to kind of go back to basics and be looking at a lot of that stuff.
I think that's great. I think that's really proactive. And again, that thinking and that helps you not just be reactive.
Yes, right.
You know, and I think PCAs are well set up to support their member clinics to get into that more proactive space. I actually personally feel like academic institutions are just starting to find their footing in this area. There was so much reactivity early on, and then we see with even some of the non-healthcare issues, you know, with Columbia and Harvard and those institutions, how now they're finding their footing and they're realizing, hey, we can have a voice, we can have a strategy here, we can prepare ourselves for not just defending our turf, but potentially, you know, engaging more productively. I think that's fantastic. And Susan, I see your comment there. I wanted to kind of highlight that. Yeah, change is hard, and feeling performative about the language stuff is tough for people who value words. And I think in general, as folks who are highly educated, we do value words differently than the rest of the population. You know, the truth is that most of the population couldn't care about words. I think that's something that I've learned over this election cycle, right? And that's something just to note, right? It's not a good or bad thing. It's just we just have to be aware that for us, those of us with graduate level education and healthcare, words mean a whole lot. For most people, it doesn't really, you know, words are not as powerful of a thing, at least not these kind of words. And so, you know, it's tough. We got to swallow it a little bit and then just kind of say, all right, where's my opportunity here to grow? Because the truth is, I kind of like that BEAM acronym. It's the first time I've heard that one. Just because it does feel so inclusive. Like it's like, man, that's awesome that we're highlighting folks with accessibility issues and mobility issues alongside everybody else. And to me, anyway, those words mean everybody. So that's sort of the reframe that we have to kind of go through for ourselves.
I think that, thanks, Neff, for saying that. Like, you know me, so
Yeah.
it's definitely hard to swallow, but it doesn't mean, I always think about process, not perfection,
Mhm.
and just keep moving forward and doing a lot of like calling in versus calling out, you know, like, well, what do you mean by that? And then realizing that they're all, you know, just trying to keep their jobs and still do the work without feeling like, you know, a sellout. I think that's the hard part. So I appreciate your comment on that. It's very helpful.
Awesome.
Well, I appreciate you expressing that because I think all of us have felt that same dynamic at some point or another in the last 4 months, right? Writing something, talking about it.
Well, this has been great. We are just about at the top of the hour. Thank you all again for joining. Want to just reiterate to take care of yourselves, feel those frustrating feelings, and then turn them into some kind of action if you're able to, right? But even just engaging in this way and showing up means a lot and is helpful for me. Neftali, thank you so much for your leadership today. And hopefully we'll see you all again on the next call next month. Everybody has
Have a great day, everybody.